We're going to have a change of tack now, and we're going to have a case discussion. And I'll introduce our first speaker, but also those people who might contribute to the panel discussion, but everyone's welcome to ask questions. So the case will be presented by our registrar, Dr. Julian Harris. So Julian's come to us from Cairns. He's a dual trainee in general medicine and infectious disease, and this is his first year of ID. And like so many of our trainees who spend time in North Queensland, he brings a huge amount of experience, and he's obviously got an interest in tropical disease. And our panelists are also going to be Dr. Alex Chaudhuri, our Director of Infectious Disease at Prince Charles. And Alex has a broad range of interests, not just clinical medicine, and he's done a lot of leadership work and work at Pasteur Institute and at Harvard as well in the business school. And we're also going to have Dr. Kanthi Vemuri. I'm not sure, Kanthi, if you're online, but Kanthi was also one of our ID Advanced trainees and has been over in North Carolina doing a transplant fellowship. And so Kanthi's coming back to Australia soon and joins us from God knows what time it is over there. Kanthi, you're looking very good for midnight. One of my favourite parts of my week is at Prince Charles. We have our Tuesday ID meeting. We just sit around and shoot the breeze and talk about tricky cases, and you can say anything sort of silly idea you want and no one sort of shouts you down. So it's a collegial atmosphere we have. So Julian's going to present an interesting case. Alex and Kanthi can maybe make their own comments, and I'll try and coordinate the conversation as we go. Thanks, Julian.
Thanks for the opportunity to talk today. So I'd like to discuss a challenging case that we were involved with earlier this year. So our patient is a 51-year-old woman born in Scotland, living independently with her husband in out of Brisbane, and she previously worked in hospitality and as a dancer. She had cystic fibrosis and had a bilateral sequential single lung transplant in 2008 with a number of complications which had been inactive for some time. She was stable on prednisolone, 10 milligrams daily, tacro and mycophenolate, and had azithromycin, Bactrim and valganciclovir prophylaxis. She had well-controlled diabetes on insulin and had stable CKD4 with an eGFR between 25 and 30. She'd had a lot of admissions during the previous year with recurrent rhinosinusitis. So in December of last year, she had an admission from clinic where she described 3 months of gradually progressive short-term memory loss and low mood. She had no personality change, no focal neurological deficit, and she had no other localizing symptoms and was systemically well without epidemiological risk factors for specific infections. Interestingly, at the time, her MOCA was noted to be 23 on 30, consistent with mild cognitive impairment, and she lost 2 points for language and 5 for delayed recall, only getting 2 out of 5 of those right with a multiple choice cue, suggesting so this suggested that there was some significant encoding dysfunction. She had an LP. Initially, the CSF looked quite bland, and that was sent for a number of additional investigations. She had an MRI, which was reported as normal. And eventually, the HHV6 DNA was detected both in her CSF and serum, and a host of other investigations were all negative, which I'll show shortly. So at that stage, there were multiple teams involved in her care, and the working diagnosis was of the neurocognitive symptoms of unclear cause, possibly a concomitant mood disorder, and whether this was contributory or a result of her symptoms wasn't clear. The HHV6 PCR positivity in CSF was thought to be of unclear significance. She had non-specific symptoms and a negative MRI, and whether this was causative or asymptomatic reactivation, potentially lyse cells with detection of latent infection, or chromosomal integration was unclear. Although encephalitis was thought to be possible, it was felt that the low pretest probability of a diagnosis was inadequate at that stage to justify intravenous ganciclovir and hospitalisation, and so she was discharged with an increased oral valganciclovir dose and a plan to review her progress in clinic. So in January, she's had a month of treatment and there's no meaningful change. She's seeing a lot of other specialties and there's an alternate working diagnosis. And so at that stage, it's thought that this is not HHV6 encephalitis, and her Valgan was reduced back to a prophylactic dose. Unfortunately, in March, she's readmitted. She's got ongoing functional decline. Her short-term memory loss is now marked. She's having falls and worsening mobility at home, but there's no focal neurological deficit and she's got no other localizing symptoms. Her MOCA's declined now to 20 on 30. An MRI is done, which shows that there's progressive hippocampal atrophy, and that's marked. The medial temporal atrophy score is reported as being 3 on 4, and retrospectively is reported to be 2 on 4 in the previous MRI, which is abnormal for a patient of her age and education. And having the HHV6 on the request form meant that the radiologist suggested this is likely to be sequelae of HHV6 encephalitis. And here you can see the progressive hippocampal atrophy on the MRI. An LP was again done with normal white cell count, and the HHV6 DNA was detected. She had a number of negative serum tests, as well as a host of negative CSF tests, which I won't get into. So at this stage, our diagnosis is suspected HHV6 encephalitis. Serology and quantitation was requested, both current and for historical specimens, and IV ganciclovir was initiated. During her treatment, she tolerated this well without any evidence of toxicity and had therapeutic levels. So adding on the quantitation was challenging, and the reports came back that the cycle time indicated that only a low level of virus was detected, both in the serum and in the CSF. The serology was negative for RGM, but an IgG wasn't done. And HHV6 PCR, interestingly, added back in May of 2022, was also positive on her serum. And the significance of that is not clear. So on the rehab ward, unfortunately, her progress is poor. She has progressive decline in her mobility and her cognition. The PCR remains positive both in CSF and blood. And foscarnet and cidofovir are considered, though contraindicated in her renal failure, with her GFR sitting between 20 and 25 at this stage. Again, cyclovir is extended, and resistance testing is explored, but unfortunately isn't available. So multiple samples were sent for HHV6 quantitation during her admission, and all of them came back with the same report that the cycle time was too low to formally report a quantitation. And just for interest's sake, I've presented the cycle time on our QPath specimens, showing that there was no significant difference before initiation of therapy or during her therapy. And unfortunately, her MOCA, as you can see, continued to decline. Imaging at the end of the 5 weeks showed that there was no significant change in the hippocampal atrophy from the start to the end of her treatment. So our final impression was that this is probably HHV6B encephalitis, and we suspected that ganciclovir resistance may have explained her poor response to treatment. The clinical syndrome and imaging was consistent. We hadn't found an alternate diagnosis. The low-level CSF and serum HHV6 quantitation we thought was sufficient to rule out chromosomal integration, where we'd expect much higher levels. Although the diagnosis we felt was a little unclear, current guidelines in stem cell populations suggest that any CSF PCR positivity with a consistent syndrome and no other cause was adequate to make a diagnosis. Though certainly it's well described that there can be low-level detection of non-chromosomally integrated HHV6 DNA in CSF in the absence of encephalitis. And anecdotally discussing with some colleagues, that's been a similar experience locally with the rollout of the BioFire panel. We had a family meeting at week 5 where it was felt that further treatment with ganciclovir was futile and we didn't have safe alternative options, and so treatment was stopped. She was discharged home with her husband and increased support. So I guess lessons from this for us were, from a technical perspective, that although quantitation is thought to be helpful, if it's high, we're not really able to differentiate between chromosomally integrated HHV6, as we don't have the capacity to assess copies per cell. There's no clear established threshold looking at the literature in quantitative PCR to differentiate between active, asymptomatic, or late reactivation or latent infection, and we didn't have access to ganciclovir resistance testing. Thinking about the way we thought about this case, I suppose there was some uncertain significance of the positive results, and certainly there was a risk of bias to act on these results, and the long-term turnaround time of the quantitation did make things challenging for us. Our approach, though, was that it's hard to ignore these MRI findings, plus a clinical presentation that was typical for this infection, and a CSF PCR that was not negative, and so we decided to treat based on those. Our options were limited, unfortunately, by her comorbidities. Questions that we had at the end of this case were, well, were we detecting asymptomatic reactivation or latent infection, and how could we discriminate this better in future? Acknowledging the limitations, is there any role for the CT value to predict the failure of the formal quantitation and save sending so many specimens away for quantitation? Was there poor progress really due to treatment failure because of ganciclovir resistance, which we suspected, or was there an alternate diagnosis? Is there any role for omics in making a diagnosis? And in future, what would be the role for alternate therapies? There's certainly some in vitro data and case reports for susceptibility to HHV6 with artesunate, and I know there are some trials going on for brincidofovir and T-cell therapies, which may have been better tolerated or options for this patient. So that's where we're up to with the end of the case. Thought might be an opportunity for some discussion and see what people thought.
Thanks, Julie. That's really interesting. I sort of like it that it's not a clear-cut case, isn't it? You know, we don't, like a lot of things in clinical medicine, we don't always have a clear answer. Alex, you just sit up here on maybe you can sit up on the stool, and Kanthi, have you, I might just go to you first of all. Actually, just one quick question. This idea of chromosomal integration, can you just, and what that means for the, in terms of interpreting the test?
Yeah, of course. In terms of the exact mechanisms, it's something I'm probably not the best person to talk to you about, but up to about 1% of the population can have integration of HHV6 DNA into their genome. About 1/3 will be HHV6A, which is not thought to have any sort of pathogenic potential, but about 2/3 will be 6B. And so in these patients, often we'll find very high levels of HHV6 DNA quantitation in the absence of disease, just because it's integrated into the host genome. And so I think differentiating that from infection can be challenging if you get really high quantitations. Yeah.
So, Kanthi, just what would your differential be for a patient like this? I mean, forget about HHV6 for a moment. She's about 13 years post-transplant, and just in one sentence, Julian, just how she presented, again, her symptoms?
Certainly, it was just predominantly gradual short-term memory impairment, and then later on some mobility issues, which was actually initially attributed to just general deconditioning rather than a specific neurological deficit.
Thank you, Julian, for the case. And yes, it is so challenging. And even HHV6 is some kind of a testing which, you don't want to go up first and order it just because of the same reasons that you have mentioned, is because the interpretation is so challenging. So taking a step back and looking at this as what I think in my head is like a non-neutrophilic, meningitis/encephalitis, more this patient presenting with no focal neurological deficits and mainly cognitive decline, more is in place of some kind of a subacute process as opposed to like an acute infection. So when you're thinking about some subacute onset of cognitive decline, you're thinking about, yes, possible reactivated infections, such as like, what we see as, VZV or, like the viral infections, which like CMV and things like that. But also, I think the differential here is very broad. We need to remember to think about the previous patients pre-transplant and also post-transplant environmental exposures in terms of any, I would be thinking about syphilis in this situation as well. Things like other tick-borne illnesses in the past, such as, like Rocky Mountain spotted fevers and, other infections rather than acute bacterial infections. But also always in the back of my mind in patients like this, I also think about non-infectious syndromes as well, in terms of like, is there any other, neurological encephalitis, inflammatory encephalitis syndromes, which is where, it's very important to get the neurologists on board and think about, antineuronal antibodies. And also the immune suppressive agents themselves can cause such syndromes, which we see sometimes acutely as, like PRES or even other drugs such as Bactrim and, where we've seen encephalitis syndrome. So this is what I would be thinking on lines when I see the patient first. And of course, the radiology, the neuroradiology always also kind of helps us too.
Thanks, Kanthi. So Alex, how much evidence do you think you need? This is obviously a tricky one, isn't it? Often we get excited, and you spoke about bias, cognitive bias, and anchoring bias. We always use these terms. We get excited that we maybe found an answer. And I guess there's limitations of treatment options and toxicity. And what do you think, Alex, about?
Yeah, thanks. And thanks, Julian, for being so succinct yet quite comprehensive in that case presentation. I learned a lot from this case. And I think the cognitive bias here, we always like to reflect on it, especially in the Tuesday meeting, had to do with the initial MRI, I suspect, being reported as normal, knowing that it can be normal in HHV6 encephalitis. So I think there was that. There was partly us not wanting to grapple with the fact that our kidneys were terrible. And this could be conscious or subconscious. Why did we not treat early on? So that was one thing in hindsight. I think we should have reconsidered more aggressive treatment, perhaps, to be fair. The second issue that we've had, and the hardest one to resolve, is distinguishing between acute infection or active infection and chromosomal integration, which is sometimes inherited through the germline. So the viral genome is integrated into the person's genome. So, and it was near impossible for us to resolve that from a laboratory point of view. Having said that, in hindsight, I think in the future, if we had a similar case, we would make this distinction between what's the quantitation in blood versus CSF. So if it was really high in blood and low in CSF, you could say, well, maybe this is CI, not active infection. But if it's low in blood, couldn't possibly be integrated in all your cells. So I think that was a good lesson for us. I think we need to read the literature to see if other people have done this. But really, if you have a read, it's quite sparse in how you approach it. In summary, if the clinical radiological syndrome is consistent and the PCR and the CSF is positive, effectively you get treated. But as you can see in this case, it wasn't as simple.
And the panel for the herpes viruses, is that just a multiplex panel, or do you specifically ask for each of those?
Specifically asked for the HHV6, 6, 7, and 8. Although I believe it's been on the BioFire CSF panel now, but I'm not sure if it's still being reported. I think given some positive results, maybe some of the people who know more about that can enlighten us.
I hadn't come across a case of HHV6 encephalitis. Has anyone else come across those? Yeah, people in the front row. Yeah. How did they go briefly? Julia, you're shaking your head. I might just give Julia the microphone. So it's got Julia Clark, Associate Professor Clark from the Queensland Kids Hospital. Yeah.
Hi, thanks. This is really timely and really fits into the discussion that Adam wanted to have about collaborations and what we're all doing and really learning off each other. Really, really important. So I had two comments. One was we had in primary immune deficiency child who was bone marrow transplanted last year, who had a very similar story to that. And we went down the whole integrated HHV6. How do we measure this? Is anybody from the lab here? I annoyed them hugely about trying to find that. We spent a long time trying to find somebody who's going to do it. We had it all packaged up, ready to go to the US for $40,000. But there's somebody in Prince Charles who will do it. So there's a research scientist in Prince Charles, I'll tell you later, who is doing some research looking at integrate and can run integrated a diagnostic process for integrated HHV6. Our child did not do well and unfortunately passed away with what appeared to be clinically HHV6 encephalitis. And we're currently having exactly the same conversation about a very young ADA SCID who has HHV6. And that is really interesting because has had HHV6 from probably less than 3 weeks old. And so the clinical perception is that this almost has to be integrated, but is a very low level. So may well not be, and clearly has implications for ongoing bone marrow transplant. And the last thing is, did you know it was HHV6B or are you just guessing?
No.
Because you can also test for that.
No, we didn't test for A or B.
So
that was one of the questions we had, whether we could.
Yeah, so we can do HHV6A and B at Prince Charles. Let's put you back together.
Yeah. Thanks very much.
So I think HHV6 testing and laboratory processes are a very useful discussion to have and to continue to have as a group, because we probably can then move things forward a little bit.
I think it sort of makes a point, and Chandima sort of touched on this as well, about working with research labs in a real-time clinical experience. So with UQCCR being able to do some of the more susceptibility testing for the ureaplasma and mycoplasma, even though it may not be validated. We all like to say, oh, it's not validated for clinical use, but I guess knowing who's around who can do these.
Yeah, so I just want to, because we had 2 cases of HHV6 with our group just this year. We haven't seen it, like this, and then pretty similar presentation. And the first case was again for MRI. First MRI was negative. We're detecting this. We did quantitative study, CSF positive. We treated that patient, but by the time he presented, it was all memory issues. He cleared the virus, but his memory or functional level never came back. And it's a disaster now. Like he's about 1.5 years after transplant. He can't remember anything, what he says. So that was the first patient. We managed to get it cleared. And the other things we use is we gave IVIG. He was hypogammaglobulinemic, so I don't know whether that helped a bit.
She wasn't hypogammaglobulinemic,
Yeah.
but was also on IVIG.
IVIG, and then we reduced the immunosuppression sometimes, but then it led to rejection. But so that's him. And then there's another case now, another patient who came many years out down the track. She came with same problem, memory issues, and she still had a positive PCR after being on ganciclovir quite a number of weeks. So what we still continuing on and probably resistant. We couldn't do resistant studies again. So we are not sure where it's coming from. Yeah. So I didn't know about that.
Maybe just all did you just want to make a brief comment before we go for a break about your experience? I think you had your hand up as
No.
oh, it wasn't you, sorry. Okay.
But that's okay. Yeah, we've had a bone marrow transplant. Sorry, an acute leukemic patient who was going for bone marrow transplant who had HHV6 as well, and we were wondering whether it was encephalitis or not. We treated the patient and we actually cleared it, and we didn't actually prophylax them going into transplant. So and they've done well. So it's quite a difference in variation as well. I do also think that A and B is also very important to determine, because they actually do have different sensitivities to the different antivirals as well. So it is important to remember. And A is got higher ganciclovir levels than B. So it could be that if you couldn't tell whether it was A or B, that may have fit into why she didn't respond to the ganciclovir. So it might be something you need to think about a bit more to differentiate.
Yeah.
Respond to that. I thought, having been on valganciclovir for 10 years and developing this on that would have predicted resistance, and the fact that there was no change to the CT values. In hindsight, we thought that was likely. Yeah. Thank you.
Well, thanks very much. We're a few minutes over time. That was a great case and had lots of discussion. So thanks, Julian, and our panelists. Thanks, Kanthi, for joining us, and hopefully you can stay on for some of the talk. I think you might be back in Australia in a few weeks, which will be terrific. So thanks very much for all those who spoke in the first session, and thanks for your questions.